association. We don't have a direct connection. We've only seen the bacteria in the amniotic fluid. And so we know there's some kind of an association, but we don't have a direct connection there. Then respiratory tract infections, we've all heard of ventilator-associated pneumonias. If the person has a lot of bacteria, which we do, but if especially periodontal bacteria, and then you introduce the tube for intubation, then you can carry that down into lungs and of course have the ventilator-associated pneumonias. They have found that if you use chlorhexidine to clean the mouth either before intubation and during the time of intubation, that we can prevent some of those pneumonias. There is bacteria that's related to colorectal cancers that is also related to periodontal diseases. And so they have found that bacteria in the mass of the cancer. They've been able to identify that bacteria there. How that occurs, we don't know, but when we've seen people who have a large amount of that particular type of bacteria, then we know that they're at greater risk for colorectal cancers. Cardiovascular diseases, again, in the plaque that builds up in the carotid arteries or the cardiac, the arteries of the heart. When we see that plaque buildup, we've also seen the periodontal bacteria in the plaque there. So they think that it is an injury to the intimal lining of the artery, and that plaque begins to develop to kind of as a scab to protect that area. And the bacteria may be what interrupts that intimal lining and then results in the plaque. Alzheimer's disease, if you think about how close our mouth is to our brain, it would think that it doesn't have to travel that far. There was a study done some years ago in Wisconsin. It's called the NUN study. There were 140 sisters who contributed their bodies to science to understand Alzheimer's disease. And what they found is that the women who had fewer teeth had a higher risk or had Alzheimer's disease. So people who had 9 teeth or fewer had a higher risk of developing Alzheimer's disease, or had the disease, let's just say, than those who had a full mouth of teeth. So these are just some examples of the oral systemic connection. I think that it's, what I tell the students is, what's in the mouth doesn't just stay in the mouth, it goes throughout the whole body, and we need to be mindful of that. So what are some of the tips and tricks and tools of the trade? I will tell you that I was part of 2 HRSA grants, as Dr. Kelly said in the introductory remarks. Dr. Barbara Overman, who's a retired faculty, submitted and received a HRSA grant. I believe it was back in 2015 is when we received the grant. It was an interprofessional grant. So a team of healthcare professionals worked at El Pueblo Health Center. That was the clinic where we were implementing the tools that I will be showing you. And this is where we were trying to do integrate the oral health into primary care. The professionals involved in developing the tool that I will show you were dentists, nurse practitioners, midwives, PA, medical doctors, and we also had the MAs contribute their thoughts on the development of this tool. So it was very interprofessional. There are 2 tools. They're called a P-Coat. It's primary care oral assessment tool. There are 2 tools. One of them is for primary teeth only, so usually used with the eruption of the first tooth through about 6 years of age. And then the second one is for permanent teeth. So with the eruption of the first permanent tooth is when you start using that one. So that's the one that I'm going to share with you today. And it's usually started about 6 is when you start getting your first primary, first permanent tooth. This is a diagram of the top part of the P-Coat, and this is where we asked patient oral health history questions. We laminated this and gave it to the patients when they came in to the reception area, and they completed it and then gave it to the MA, who then put it into the chart for the healthcare provider to see. If the person wasn't able to read or didn't want to fill it out, then the MA would read the question and they would, the patient would answer, and then it was put into the chart. And the second part of this was done by the healthcare provider. The healthcare provider did ask some questions such as exposure to fluoride toothpaste or rinse, or prescriptive fluoride exposure. And the reason for this is that the prescriber or the provider could explain a little bit more about this type of question where a patient may not understand it if they were reading it on their own. The other was an assessment of the patient's physical behavior. Were they physically capable of brushing their teeth, or were there some limitations that would prevent them from doing adequate oral care? And then the next one is vomiting or acid reflux. When we have a lot of acid that comes into our mouth, it gives us a greater risk for developing caries, but it also can dissolve the enamel of our teeth. So that's something that's important to note. We also, this is a risking tool, so we were looking to see if this person had low risk or high risk or extreme risk. When we see extreme risk, this would be somebody that I would refer as if somebody came into the clinic and had a broken bone. I'm calling a provider and saying, hey, I have somebody that needs to be casted. This in extreme risk is where I would or the MA would call the dentist and say, hey, I have somebody who needs to be seen soon, so that I'm making sure that the patient is getting care. Low and high risk is something that I would assess. If they were low risk, I would encourage them to continue doing what they're doing. If they're high risk, I would talk with them about what are the areas that they can change to improve their oral health. In the process of this, I developed something called the 4Ls exam because most healthcare providers do not know how to do an oral assessment. Most of us were not trained in that. And so this was a simple way to help people know how to do an exam. So essentially what you're doing in this exam is lifting and lowering the lips. You're really looking along the dental gingival margin for those white spot lesions that I showed to you earlier. You're also looking at the mucosa here to see if there are any kinds of lesions. And the same thing when you're lowering the lip. Then you also look at the teeth. You can look for any kinds of fillings or crowns or anything that indicate that person may have had some kind of dental caries in the past. And you're also looking to see if there are any currently active caries. The next thing is to do a lap with your finger around the gum line. What you're looking for is fistulas or areas where fluctuants, where there might indicate a current abscess or any kind of a mass that shouldn't be there. And then the last is to lasso the tongue, and really you're looking along the border of the tongue to see if there are any like leukoplakia or erythroplakia, which could be precancerous or cancerous lesions. So this exam can be done in less than a minute, and I'm going to show you that. Oopsie. These are two of my students. You won't be able to hear them, so I'm going to explain what she's doing. They gave me permission to show you this video. The one student is explaining to the other about the oral exam. And if you time her, you'll see it's really quick. So here's where she's looking at the lifting and lowering the lips. Now I would have her pull those down a little bit more so that she can see the dental gingival margin. And then I'd have her lift that lip a little bit higher so that you can see all the way back to the sulcus. And so she's doing the lap around the gums now. And she was also looking at the teeth a little earlier. Again, she's doing the lap. Here she's checking the palate. And now she's looking at the buccal mucosa on both sides of the mouth. And now she's doing this with the gauze. And now she's checking the side of the tongue. And she's looking at the tongue itself for any kinds of lesions, and you can see that that's all over. That took her less than a minute to do. And that's something that I really encourage my students to do, because you can see it doesn't take long to do an oral assessment. This is the whole tool that I showed you parts of. On the right-hand side, you can see that we give instructions to the healthcare providers about what they can talk to the patient about. so that if they're low risk, you just encourage them to do what they're currently doing. High risk and extreme risk, you do not have to do all of the pieces that are suggested here, but those that are appropriate for the patient. And next, I'll show you self-management goals and what we would do with the patients on those. This actually comes from the American Academy of Pediatrics. These are self-management goals that you can show. And usually I would ask the parent to choose only one, because change in behavior is really hard to do. So if they would choose one, then I would mark that on my sheet. And then when they came back the next time, I would review with them, how did that go? Were you able to be successful in implementing that change? And if not, why not? That was for the peds, and so we wanted something more for adults. So we kind of adapted what was done there and developed something more that you could use for more adolescent and adult patients to help them make choices in changing care.
Dr. Kogel, you have 3 minutes.
Okay, thank you. So I'm going to go on into prevention measures. Fluoride, as I spoke earlier, aids in the remineralization of teeth. This is white spot lesions. If we did high dose fluoride toothpaste or even fluoride toothpaste or fluoride varnish, that would reverse these so they do not become cavities. Fluoride acts as a carrier to bring calcium and phosphorus into the enamel of the tooth and to help it to heal. Prevention measures that can be done is to brush twice a day with fluoride toothpaste, and for the reason I just spoke. Daily flossing removes removes the plaque that is developing on teeth that can cause periodontal disease. To avoid saliva sharing, and that's really hard to do with our small children. And then to have dental hygiene every 3 to 6 months. Typically, if you're at low risk, then every 6 months is sufficient. It just goes in and cleans out the plaque that it develops on all of our teeth. People with periodontal disease need to do that more frequently. And then to limit your starchy foods to mealtime only. So you can have all the sweets you want, but eat them at mealtime. That's when your mouth is really acidic. And then let your mouth rest, let your teeth rest in between times. And use things like, if you need to snack, use things that are not carbohydrate, and such as cheese or vegetables or water and sweetened beverages. So those are recommendations, simple recommendations that you can give to people. Finally, I want you to know about the dental resources that are available for people. Federally qualified health centers are required to have a dentist, and they may not have one on site, but they have to have one as a referral. So the federally qualified health centers are required to have a sliding fee scale, and they would require that of the dentist. Dental schools or dental residencies like we have here at UNM also have sliding fee, and the dental hygiene school here at UNM does as well. And then I often encourage people to develop a relationship with a local dentist. One of the things that we know is that only 20% of dentists in the United States take Medicaid. And a lot of that is because of the structures of reimbursement or low reimbursement, or all of the paperwork that's the administrative piece of that takes so much time. So finding a local dentist that you might be able to work with to take your patients is a good way to be able to have a resource to refer your patients to. So with that, I am open and would love to entertain any questions that you might have.
Fantastic. Thank you, Dr. Kogel. We appreciate your presentation. We're now at the Q&A part of our program. My name is Marlena Bermel, and I am the Director of Alumni Relations for the College of Nursing. If you have a question for Dr. Kogel, please write it in the chat, or you can virtually raise your hand using the reaction button down at the bottom of your screen. And we will, I will help call on people and ask questions of Dr. Kogel as they come in. So do we have any questions to start us off? Dr. Taylor?
Excellent presentation, and I agree that there's so many positive outcomes when we're able to integrate oral health into care. And I'm curious, with the P-code and the oral health self-management handouts, what other languages those were translated into?
None. They're in English only. I'm sorry, we did translate them into Spanish.
Okay, thank you.
Yeah, I'm sorry. I just haven't had those for a while, so yeah.
We have a question here in the chat from Dr. Lavin. Do you know what percentage of providers actually perform oral exams?
Well, I can tell you this, based on the reading that I've done, only 5% of med schools provide this education. And so I got interested in this because when I first went out to practice, I wasn't trained in any assessment of oral health. And I really came across this a lot in my work on the border. I worked on the Texas-Mexico border, and that's where I got interested. So I would say very few, though I'm currently involved in working with out of UMass and Harvard. There's a group that's really trying to increase the integration of oral health into our educational systems. So hopefully we'll see an increase in that, but I do not have any specific data on how many people actually do this.
Wow. Dr. Kelly asks, in your case study, did the person drinking well water not have fluoride?
So that's a really good question. It's really hard to find out. Actually, people who have well water can send it in to the state and have it analyzed for fluoride. There are parts of New Mexico that have way too much fluoride in their water, in their well water, and that can cause something called severe fluorosis. And so I didn't go into all of that because I didn't have time to do that in this presentation. Most 75% of New Mexico's cities, towns, whatever, have fluoride supplementation in their water or removal if there's too much. It's the people who live in rural areas, which is a really good point, who may or may not know about the fluoride in their water. So as a provider in a rural area, you can encourage people to send their water in and get it tested.
Dr. Shannon asked, do you have any recommendations for providers who meet administrative resistance to incorporating dental health into primary care clinics?
So it's one person at a time. So what I say is that, you as a person, and one of the things I will say to Dr. Shannon as a PNP, and to all of you really, is that in the state of New Mexico, Medicaid will cover for us to apply fluoride varnish to children from 0 to 20, and we can be reimbursed for that. Okay, it's very inexpensive to do. And what I have seen in primary care is that when one person starts doing this and becoming an advocate for it, and it really does take somebody being an advocate, then other people fall in line or they start asking you, well, now tell me why you're doing that. And once they really can see a difference in their patient population, then you get a buy-in, but it takes a while. So I say one at a time, and if it's you to start it, that's fantastic.
Fantastic. Dr. Rogers asks, what policy recommendations do you have to support us in this work?
So policy recommendations. So one of the things we did on the grant was we got, so there was something in place for reimbursement. It wasn't happening. And Dr. Jan Martin worked a lot on getting that in place so that Medicaid would turn on in their end, whatever the state end was, for us to get reimbursed. As far as policy, I think first of all, it's an awareness, and then we can start working towards policy change. It's great if you can get people from the top end, like saying in our measures, like, hey, you need to have an oral assessment. If we could have that as part of the measures for all of our clinical care, then that would start making a difference. Then people would start saying, oh, I've got to learn how to do this, and I've got to include it in my practice. Just as we ask people, do they smoke? Do they wear seatbelts? Do they do all of those things? If we would implement this as one of the requirements, then we could see a difference in practice behaviors.
Thank you. Is there any other questions for Dr. Koval?
bottled water, I saw that. Is that okay? So this is an often one that I get asked about bottled water and filtered water. Filtered water, many filters filter out the fluoride in the tap water. So really the recommendation is to drink tap water. Bottled water, we have no clue. It could come from some little town in Arkansas, and that town may put fluoride or may monitor the fluoride in their water, or they may not. So, and I say Arkansas probably because that's where Walmart's based and maybe they sell the most, I don't know, but I'm just pulling that out of my hat. Not to blame Arkansas, but just know that we don't know what's in bottled water. So really my recommendation is just to drink tap.
All right, do we have any other questions? Okay, well, thank you, Dr. Koval. We appreciate your presentation and all sharing your knowledge with us.
Oh, thank you. And thank you for inviting me. It was fun to do.
Absolutely. I'm now going to turn it over to Dr. Kelly.
Hello, everyone. I'm back again by popular demand here to thank you, Dr. Koval, for this impressive presentation. And I learned quite a few pieces of information, and it reminded me of some other information. I would like now to introduce Dr. Lisa Taylor. She is one of our assistant professors at the College of Nursing. She's a family nurse practitioner and a certified diabetes care education specialist, the new name for the former CDEs. Dr. Taylor has a broad interest in diabetes, including how patients learn about their complex diseases and how diabetes and living with diabetes in rural border states. And she is interested and invested in educating the next generation of healthcare practitioners to be culturally competent and humble in their care delivery. She has spent the bulk of her career as a nurse practitioner, providing care in rural and underserved populations in both Maryland and New Mexico. I would like to welcome Dr. Taylor, and we look forward to your presentation on diabetes health. Thank you.
Thank you. Thank you for the invitation. It's an honor. I'm coming up on my second year at the university. So when I received the invitation, I was quite pleased because I also get to have a captive audience when I get to talk about diabetes. So no one go away. It's going to be fun. Here. So let's see if we can get this thing to work here. Okay. Can everyone see this? Excellent. I've seen it hot heads nodding. Excellent. So we're just going to talk about diabetes health. And while that sounds like a daunting task, I promise we're going to meet the objectives that we covered at the beginning of the presentation and our time together. And you're going to leave, as I tell the students, when you stop learning, you die. So when you leave here, you're going to know something new. That's my goal. Okay, let's see if we can get this silly thing to work. There we go. Okay. I have no disclosures. And this is a picture of my mom. So today's lecture is dedicated to my mom, who, gosh, it's now been 14 years since she died from the complications of diabetes. So this is why I do what I do. Okay. And I'm going to minimize this so I can see my own work here. So our objectives, again, were previously indicated when we started our time together, but consider the increasing prevalence of diabetes in the United States, particularly in those populations most at risk. What are some of the practice gaps? What is the evidence to support these practice gaps and future implications for practice? So I have a couple of examples that I wanted to share of patients that I've seen within the last couple of years. So a Native American Indian woman in her 60s came in for diabetes care, and we were going to look at her medications and do some adjustments. And she advised me at that time that her previous provider told her A1C of 7.8 was quote unquote borderline diabetes. And what we know, if someone has looked at a journal, they've been to a conference, they practice in the world in which we live, 7.8 is very much a diagnosis of diabetes. So think about the implications for her care and the delay in her care, because if the provider is advising her she's borderline, then there's medications and things that aren't in place, including being more cognizant of her oral health, her vision health, mental health. So it really does her a disservice. And I had another patient, also older, and she advised me that her son's primary care provider at our local VA told him, quote, "We don't use the A1C to diagnose diabetes in Black people." Again, standards, whether you use the American Association of Clinical Endocrinologists or the American Diabetes Association, we use the A1C for pretty much all populations. There's some exceptions for pregnant women. There's some exceptions for sometimes in children, and also when we're dealing with people who have chronic kidney disease, particularly end-stage renal disease, but we use this in all populations. So my question to you, my ask, what do we do next? What contributes to these practice gaps or lapses in care? So some background. Bob in 2011 suggested strategies to achieve the goals of Healthy People 2020. Those strategies have not necessarily changed because we haven't met the goals of Healthy People 2020, and now we're working on Healthy People 2030. Working within myriad sectors to improve policies, we also need to strengthen practices based on evidence, knowledge, and research. We also have a need to work with an identified community to better assess what the desired health outcomes could be and should be, particularly outcomes that, quote, promote health, prevent disease, and encourage participation in healthy behaviors, end quote. And certain communities, for example, Hispanic adults with an identified history or risk of prevalent chronic diseases, such as cardiovascular disease or obesity and diabetes, we really, again, need to consider, who do we serve? Who do we have here in New Mexico? Where have we done well, and where are there areas for improvement? And again, I'm going to give some background here for my DNP project. When I started my DNP project in 2012, my intent was to study Black grandparents living with diabetes who were raising grandchildren, because in many, many communities, the primary, or as I say to kiddos, who's your important adult? Often that important adult is a grandparent. It could be an older brother or sister. It could be a cousin. In many cultures, mine included, the idea of family is very fluid. I know today I have many spirit brothers and sisters here today. So I embrace you. But again, when we think about family, my purpose at that time, my goal was to consider the evidence around how do we prevent diabetes from generation to generation. And at that time, two of the overarching goals for Healthy People were to be free of preventive diseases related to weight and height and diet, and to eliminate health disparities. We're, as I said earlier, still working on that. I was living in the South, and then I moved to Maryland. So again, had adequate sample of people to work with. And then in 2013, I moved to New Mexico, and I've never looked back. I love living here. While I did start in Artesia, and that was a bit of a cultural experience, I love being in Albuquerque, and I love being able to touch the next generation and work with my colleagues who are very sharp, very knowledgeable, very much committed to cutting edge research and applying evidence-based practice. So I had to adjust my project. And there are clearly some different demographics between Maryland and New Mexico. Many, many, not just the blue crabs. So an opportunity that I talked about in the clinic in which I was working was, what I wanted to do is to be able to contribute to the assessment of health outcomes, and ultimately lead to encouraging healthy behaviors. And again, that has to be community and culturally specific, because as we know, diabetes is not one size fits all. While we do have clinical guidelines that guide our practice, we know we have to be sensitive to and consider the populations that we serve and the communities in which we also live and serve. So in the clinic setting in which I was working at that time, I wanted to look at Hispanic adults who were at risk for developing type 2 diabetes. And this is a very busy slide, so I'm not going to read this to you. The slides will be available to you at the end, but what I can say is I did this in a community clinic, and it was selected because patients in that area, as well as our triage nurse, knew that this was a place that was safe. There was the knowledge that it doesn't matter if you have papers, it doesn't matter if you're legal, if you're an immigrant or an emigrant, this is a safe space in order to do this work. And this knowledge will help you and help future generations. So in that regard, I was still able to consider if somebody is at risk or they have diabetes, how do we kind of break that cycle and prevent that in future generations. So the literature search at that time demonstrated that there was not specific information about how to prevent diabetes in rural communities. And we know that's big, but again, more of our country is rural than it is urban or suburban. And there were also limited resources directed towards just what do we do? We know we have the National Diabetes Prevention Program, but beyond that, there wasn't a lot of specific literature to identify what are interventions that we can do that are both valid and reliable. So I had a small sample. 56% of the participants reported a family history of type 2 diabetes, and the most common family member identified was the mother or grandmother. We did the diabetes screening tool, which I will show you later, and those with the score of 5 or higher are at increased risk for developing diabetes. So the number who scored at or below 5 was 5, and the number who scored above was 12, or 79%. And then I've got some information there about my analysis. So my hunger for diabetes had already been sparked, but now it was an opportunity to change. How can I do this with my newly adopted community, with the populations that I serve now? So I want to talk about some trends in diabetes, and you'll notice that these figures don't go beyond 2020, and I suspect some of that may be because we had a pandemic. And in terms of collecting data, analyzing data, even our own state has been challenged to stay on top of what's the incidence and prevalence here. So this particular figure shows diabetes incident trends from 2000 to 2018. There was a declining curve after about 2009. Lots of factors going on there, not really clear based on the data that was used to generate this. Why is that? What happened in 2009? What we know in our state is it didn't go down. So while this is looking at the nation, we know in our state, in most populations, the numbers continue to climb. Compared to adults ages 8 to 14, the incident rates are estimated to be higher among those who are, so I'm sorry, compared to adults 18 to 44, the rates tend to be higher in adults 45 to 64 and among those 65 years or older. And for many of us who practice here in New Mexico, I know we have a range of clinicians and researchers here, so the populations we work with are varied, but that says something. 45 to 64 or 45 to 65, that's our workforce, right? That's a viable part of people are raising families, perhaps they're working, getting second or third degrees. This is a population that we need to be healthy because of all that we need them to do, especially in terms of taking care of future generations. So again, a little bit more information about what are we talking about here. So about 34 million people, or 10% of the US population, have diabetes, whether diagnosed or undiagnosed is significant in 2018. This includes 34 million adults ages 18 or older. So again, if we bring this back and we look at the larger lens of people 18 to 65, living with diabetes, some of whom know, some of whom don't know, some of whom are seeing clinicians who don't know. It says something. It says something. And this should say 13% of all US adults, or 7.2 million, again, had diabetes, but were not aware or did not report that they had it. This is something significant. Adults ages 50 years or older with diabetes tend to die almost 5 years earlier. And the literature did not reveal if this figure differs for different ethnic groups. They develop disability 6 to 7 years earlier and spend 1 to 2 more years in a disabled state than adults without diabetes. So again, we're thinking about our population and who we need to educate and raise and be with the next generation. And if they're also living with diabetes, how this affects their health in the short term and the long term. So a little bit more on prevalence. So some members of some ethnic groups are more likely to have diagnosed diabetes than non-Hispanic whites. American Indian or Alaskan Native adults have the highest rate of 14.7%. And remember that the overall rate in the United States is 10.5%. That's 13% among all US ethnic groups, 12.5% of Hispanics, and that's a US Census term because we know that's controversial, but that's what they use. And almost 12% of non-Hispanic Blacks. Some other things that were of interest to me as I was putting together the PowerPoint is the difference in diabetes prevalence based on not just ethnic group, but also socioeconomic position. So for example, level of education attained and the income to poverty ratio. And that this prevalence has increased among non-Hispanic whites with less education and lower incomes among Hispanics with less education. So we're making that connection between, in this state, we know that we often have some schools that do really well at educating our students. And there are some schools that don't do well in educating our students. And those students graduate. And as adults, how then does that continue to affect their care based on their level of education attainment, and then how that also may affect their future earning power. And Dr. Kogel gave an excellent example of a young woman who, through no fault of her own, is now living with dental disease, which could very much affect her future earnings. And depending on if or how that dental health is addressed, also increases the risk for diabetes. So this is a map of the United States. This is from the CDC. And this data was from up to 2019. And so it gives you the percentage across the country of diabetes. And we're going to focus here on our state of New Mexico. So diabetes in New Mexico, this bears out what I said earlier in terms of different ethnic groups. So we have the, it's male and female, but the highest is American Indian, Alaska Native, followed by male Asian Pacific Islanders, female African Americans, Hispanic is about the same, white is about the same, and then this is the overall trend in New Mexico. So you see where some ethnic groups are clearly trending higher than New Mexico, and they're also trending higher than what we see in the United States. And then I'll draw your attention to this part of New Mexico. So I have some notes here because not being native born here, I sometimes get my counties and my cities confused. So we'll start, and I also wanted to draw your attention to these counties here are on the border with the Navajo Nation. So we often have patients who cross back and forth for care. They cross back and forth for work. And so we need to consider culture, ethnicity, economic, cultural practices. All of these things affect how we deliver care. So I'll start with, this is the latest data was up through 2018. So we'll start with San Juan County, which has a diabetes rate of approximately 11.5%. And again, the US rate is 10.5%. And they are more vulnerable than almost 92% of all US counties. Then we go to McKinley County, a rate of almost 16% and more vulnerable than almost 99% of all US counties. So we're talking some very vulnerable people with very high rates. If we overlaid the dental information that Dr. Kogel shared with us earlier, I would imagine we're also going to see low rates of people being able to access a dentist, even if there's an FQHC located somewhere in that area. Next is Cibola, which has a rate of 12.5%, and they're more vulnerable than 99.84% of all US counties. San Miguel, their rate is about the same as the US with 10.5, more vulnerable than 98.64% of all US counties. Eddy County down here where I lived for the better part of almost 2 years, 11.4% and more vulnerable than 70% of all US counties. And then Lee County has a rate of about 11.1% and is more vulnerable than 92% of all US counties. So again, we think about where we send our students for clinicals, communities from which they come and hopefully will go back to provide the excellent care that they need and that those communities deserve. So when we think about where we have those pockets, we need to consider, we used to say this when I worked at Planned Parenthood, so what now what? What do we do with this? Because it's important that we consider not everyone lives in Albuquerque. People can't necessarily access Albuquerque for resources. So how do we look at what we're going to do for folks living outside of this area? I'll offer an example. I was in clinic last week and I was sharing with a patient the amazing resources through the UNM Diabetes Education and Nutrition Center. And I could see she's getting ready to say no until I offered, you can do it in person, you can do it by phone, or you can do by video. And then she let me put in the referral because based on how challenging it was just for her to get to the appointment that day, the idea that she was going to have to drive to Albuquerque for yet another appointment, she wasn't feeling that. But the fact that we now are able to offer telehealth and appointments by phone has increased that access. And this person happens to live in Sandoval County. But again, think about how this could impact our practice and impact resources for patients in other parts of our state, the more rural parts of our state. So I'm going to show in the next slide the risk test. It's very simple. Right now, the American Diabetes Association only provides it in English and Spanish, but it is something you can do online. There's also a paper copy. So what we know is that type 2 diabetes, chronic kidney disease, and cardiovascular disease, as well as heart failure, have overlapping etiologies, and 2 or more of these conditions frequently occur in the same patient. Preventing diabetes is a population matter. This is a public health population level matter that we need to address. So we have to have scalable and sustainable approaches to assess risk. And then when we screen those at risk, we then determine the best practices for that community, that culture. So in much the same way that Dr. Kogel referenced the P-code, and there are tools that you can use in a primary care setting. They don't take very much time, but the benefit of having that information, priceless. And this is the risk test. So there's a way to do it online, so you don't actually have to print it. When I did my DNP project, because we were in a clinic together, it was just easier to have the survey in English and Spanish. And then I also had a medical assistant who worked with me that day because I'm still working on my Spanish fluency. I'm gonna get there. It's kind of hard to read, but what it asks is, how old are you? Because we know the risk increases with age. Are you a man or a woman? If you're a woman, have you ever been diagnosed with gestational diabetes? Because that increases the risk of diabetes for her as well as her children? Do you have a mother, father, sister, or brother with diabetes? So we're looking again at close family relatives. But when I ask people and I say family history and they say everybody, I know they mean mother, father, all the grannies, aunties, uncles, cousins. So this risk test doesn't go into that level of detail, but that's information that we want to elicit from people. It also asks, have you ever been diagnosed with high blood pressure? Are you physically active? And again, that's something they're going to define for themselves. And then what is your weight category? And there's information over here with height and weight, and they put that score here. And if it says if you scored 5 or higher, you were at increased risk for having type 2 diabetes. And it says doctor, we need to change that to clinician, can tell you for sure if you do have type 2 diabetes. And then it goes into more information about what that, if that risk is not addressed, if you don't have that conversation with your clinician, the consequences that could happen. So we really want to use this not as a stick, but we want to use this as a tool. So we really understand not just folks who are already clearly diagnosed with diabetes, we're going to go down a different path. We want to be preventative. That's why we're in primary care, right? We want to do primary care, and part of that is prevention. So having this available, and I love the idea that Dr. Koga presented. It could be laminated. It's in Spanish and English. It takes them, a minute while they're waiting to be seen. It's really something that's easy, but can so much shape how we do clinical practice. So that reference is here. And then again, I just want people to consider the population. So when we're developing strategies, when we're considering quality improvement, when we're developing tools, it's important that we engage the people we're hoping will benefit. So as an example, while a patient wouldn't necessarily be able to change the risk test developed by the American Diabetes Association in that moment, if we hear over and over again, but we need to include my other family members, or it says man or woman, we need it to be more gender inclusive because not everyone is binary. So there are ways that we need to tweak this in order to make sure we're not excluding anyone that we're serving. And we really have to ask permission and talk about weight and nutrition. And if they see themselves developing a diabetes, and unfortunately, I've seen many patients who have this fatalist approach. Well, everybody in my family has it, so I'm going to get it. It's inevitable. And that's where we also want to be able to have conversations with folks about not necessarily. Because again, we're about prevention, but we're also about treatment for those people who are already diagnosed. And I wanted to give some more context. This is from Wayne Honey, who is an epidemiologist with the New Mexico Department of Health. And it's shocking when you look at these numbers that this is looking at adults less than 45 with the following conditions. So obese, ever had high blood pressure, no leisure physical activity, and they've been diagnosed with an MI, heart disease, or stroke. And these folks were not tested. So their A1C was either not done or not repeated in 3 years. So there's a huge gap of time where we could be doing intervention. We could be working in a culturally humble way with these folks, but only if we have the data that tells us what's going on. And that's up to us. Yes, we have some patients who are very savvy. Some of them are healthcare providers. Some of them are very well educated. So they come in with their list of, I want these tests, I want these meds. It's like, okay, this is not a grocery store, but thank you, we'll do what we can for you. We, though, have patients who are not going to ask. They are just going to come. They expect us to figure out, well, what tests do I need? What medications? Why am I taking it? How long? So this is a part of complacency. This is inertia. This is a perfect example of clinical inertia. And so some clinical practice guidelines. So we've got some gaps here. So the first gap, clinical practice guidelines recommend screening high-risk groups for diabetes. but with some variation in how high risk is defined. So again, sometimes you're going to need to screen earlier than the age 45 that is recommended. They've changed those so that now guidelines suggest screening based on family history and other factors that may increase the risk for developing diabetes, not simply age or, for example, gestational diabetes. Another busy slide that says, again, they recommend screening at 45, but now it can start at 35 or even earlier. Again, it's a guideline. It's not something that's set in stone. The ADA also recommends screening overweight or obese adults of any age with at least one risk factor. And screening for prediabetes and or type 2 should be considered after the onset of puberty or after 10 years of age, whichever occurs earlier, in children and adolescents who have an overweight BMI, which is the 85th percentile, or obesity, which is the 95th percentile, and also who have one or more risk factors for diabetes. I had a sidebar conversation this morning with Dr. Shannon, who's a pediatric nurse practitioner, and she's been doing this for several years and said the youngest that she's diagnosed a patient, I believe, was 7 years old. So we know as we're moving further into the next century, this is something we really need to figure out. How do we prevent? When do we screen? And what do we do with that knowledge? So this is, again, screening is one of those practice gaps. The second gap is the inertia. If you don't have the tests, you don't do the screening, you don't have the information, you can't then provide the absolute best care for that patient. And I'll ask you to think about the first patient that I mentioned when I started today, an A1C of almost 8. And she's told it's borderline, which we don't even use that term anymore. So that says there's medications and interventions that could have been offered, but not if the clinician in their mindset thinks it's not that bad, it's borderline. So we really have to work to overcome that. And I appreciate primary care can be, to say it's a zoo sometimes is a kindness. I mean, when you're seeing 22 people a day plus walk-ins, things are going to get missed. There's gaps. But again, we need to look at communities in the clinic setting, the hospital setting, the community college setting, the high school. How can we bring those partners together to make sure we're doing our absolute best? So consider the cardiovascular effects when diabetes is not adequately managed and medications are not initiated, updated, and or changed. Consider the social and structural determinants of health. Use of clinical guidelines addresses aspects of the above, but not everything. That's where the clinician and our clinical knowledge comes into play. And also when we're teaching students. So there's the practice gap of, let's see, that's a repeat slide. So we want some more of what we need to be able to consider. And some clinics already assess this through different tools, but considering food insecurity, people experiencing homelessness, financial barriers. One of my patients lives in his truck and he is reliant on his insulin. And so when his battery operated refrigerator was stolen, we had to do some troubleshooting around, okay, the weather's getting warmer. We can't just leave it in your truck under your pillow. We have to figure out what works for you, what fits your budget, what fits your lifestyle, so that we can keep you on insulin, manage your blood sugars, and then also be able to work on some of the other things that we need to work on. So we worked out a system with a cooler, and he would wrap the insulin in something and then put it in the cooler. We have to provide patients with self-management support from coaches, navigators, community health workers. I'm gonna put a shout out to my fellow certified diabetes care education specialists. We are all over the state of New Mexico. While many are housed either in health systems like UNM or Presbyterian, there are outside clinics, people who are in private practice. We need to make sure we're utilizing people within the community who know these folks best, who they trust, who will be able to move communities toward health in a way that benefits everybody. And so some of the resources through the New Mexico Department of Health, There's the National Diabetes Prevention Program, which is free. In our state, it's offered in Spanish and English and has now gone online. So you don't have to physically come to Albuquerque to participate. They have new programs developing every day. I did some consulting with a group last year, and they were working specifically with women of color who had had a history of gestational diabetes and were bilingual in Spanish and English. So the people who were presenting the materials were also bilingual women of color. There's Kitchen Creations, which is a free program. It's now also moved online and offers classes for people living with diabetes and their caregivers. There are diabetes self-management programs. There's a myriad of what they look like. Health systems have developed their own. So as an example, many of the patients we see at El Pueblo utilize Presbyterian or PMS, and they've got their own system of services for people living with either prediabetes or diabetes. And they're also working with clinicians to provide technical support. So whether it's looking at how the clinic can become a patient-centered medical home, or if they're already in that mode, what more can be done to wrap around that patient, to wrap around that community, and also utilizing electronic health records. So there's a lot of numbers out there. You know, we DNPs, we're all about quality improvement and number crunching. And so as we have more people moving into systems and looking at this in different ways, it's only going to help. It's only going to make things better. And I'm the eternal optimist. Future indications for practice. So again, we really want to approach this as a team sport. And I'm not saying that people here are not doing that, but we want to do more as we're able. So again, community health workers, social workers, to determine what metrics are you going to measure. Yes, there's the HEDIS measures that, you know, everyone gets excited about if you're a director of a clinic, but there's other metrics that we can look at that tells us, are we doing what we need to be doing? Collect data for targeted populations, and also consider the evidence for best practices in terms of outreach, outcomes, cost, work against clinical inertia. So after I saw the first patient that I mentioned, I went into my office, I did my primal scream, got it out of my system, came back, and it's like, all right, let's talk about what your options are in terms of treatment, because we have some work to do, not your fault. But again, I'm always going to come at the patient with, we want you to have the best health possible. And then telemedicine. We know that that is something that's really opened up access in our state. So perhaps as CMS is considering, will they continue the reimbursement or not, there's opportunities to work with legislators, perhaps Dr. Dameron, there's other folks in the college who have these relationships, because bigger picture, this is something we know needs to stay. And again, just making that connection back to dental health. And I'm done. Thank you so much for your time. And the last thing I'll end with is just consider all of what people living with diabetes they have to contend with. And so trying to eat less carbs, increase water intake, stay awake at work, have enough energy for the gym, not get feisty, snack on your fruits and vegetables, snack on cheese, try and, brush your teeth and floss 3 times a day or 2 to 3 times a day. It's like, there's a lot. So we really just want to be kind. And that's the thing I leave my patients with is, if you hear nothing else I've said today, please be kind to yourself, because living with diabetes is hard, really hard. Thank you.
Thank you, Dr. Taylor. We really appreciate that presentation. It was wonderful. So we're once again at the Q&A part. Again, you can put your question in the chat, or you can raise your hand virtually, and we'll call on people, and we'll continue our question and answer period. So who has the first question?
Does that mean I did a good job if there's no questions?
You did an excellent job.
Or is everyone like asleep? They're like, oh my God, what?
No, it's fantastic. So we do have our first question. Dr. Rogers said, fantastic presentation. Can you talk about the social and environmental and ecological determinants of health as we can screen for as well?
can we have that question in a slide? I'm not 100% understand the question. So is it like using a screening tool? Is it considering that as part of our screening? Help me. Oh, she's walking.
Oh, yeah, I could ask. Oh, just Dr. Taylor, I know you and I have talked about this before, but I just was thinking in terms of like the screening tools when we're seeing folks in primary care, and looking at social determinants of health as screening,
Yes.
environmental determinants of health, ecological. So I just wanted to see if you had some recommendations and you know,
like yes
for
to
us.
all.
Yeah.
I think that's one of the things that we have opportunities. I mean, we have our research team, we have DNPs who are doing research and all different kinds of projects. And so I think it begs the question, yes, the American Diabetes Association has created this tool, but is it complete? Does it give us everything that we need to know? I know one of our colleagues is looking at an exposure to, it's an environment, it's something in our environment related to nuclear waste. And what we know is there are certain biohazards, right? Certain things in our environment. Agent Orange is a perfect example that can, for many reasons, increase risk of developing diabetes. So we have to consider that. There's many more options for collaboration, I think.
Thank you. There's another question. Sorry if I missed it in the presentation. What level does the A1C need to be diagnosed with DM?
Oh, that's a great question. So 6.5 or higher. Yep. So the window for prediabetes is 5.7 to 6.4%, and then 6.5% or higher is very much diabetes. Yeah.
Great. Do we have any other questions? You have lots of kudos in the
Hey,
chat.
thank you.
Yes, you did a great job. People really like to focus on New Mexico.
Yes. We're in this together. Right? Whether we grew up here or moved here for whatever reason, we're now all in this together. So I'm super excited tomorrow to get to go to El Pueblo and talk with folks about diabetes until their eyes glaze over.
Doing good
But
work.
I'm really grateful for this opportunity. Thank you so much.
Yes, thank you too. And as mentioned, we will provide the slides for Dr. Taylor's presentation as well as Dr. Kogel. We had one more question. Are the ranges the same for adolescents?
The ranges for
A1C.
yes. The area where we don't necessarily, and I'm going to rely on my midwifery colleagues here, is when somebody is pregnant. We tend to use oral glucose tolerance tests, 75 milligrams or 100, and then we revert back to the A1C postpartum. So, and then also, there's not specific evidence to support this, but we know in clinical practice, if somebody is living with end-stage renal disease, what you're seeing is not necessarily accurate. So then you have to consider other factors to really know what's going on. And I promise I will share a slide deck where I don't have duplicates and things are more edited, because I just got tired of looking at it and missed some things. So it'll be much more clear when I send to Marlene. Yeah.
Not a problem. Not a problem. All right. Do we have any other questions before we end for this evening? Well, thank you, Dr. Taylor. Again, greatly appreciate it.
My pleasure.
And thank you again to Dr. Kogel as well. You guys did a fantastic job. So this is the end of our presentation. I just want to remind everybody to please fill out the CNE survey by April 29th. And we have that now in the chat. Also, if you come up with questions later or weren't able to ask Dr. Kogel or Dr. Taylor your question now, we're going to go ahead and put their emails in the chat as well. And you can contact them directly. Give us just a day or two. And if you go back to the website where you registered, you'll also have the PowerPoint slides provided for you. I just want to thank everybody for joining us this evening. Please come back to our website to see our next speaker series in the near future. Everyone have a great evening, and we appreciate you attending. Thank you.